Hi everyone, my name is Ifeoluwa and I am one of the Team 1 members. We are going to be presenting this case study, exploring strategies for effective multi-drug and resistant tuberculosis treatment and control in Peru. And here is a brief overview of what the slide content looks like, ranging from the abstract and down to the references. Here we're going to be talking about the abstract part. There's a brief background study of what the Peru outbreak looked like. In the year 1983, in Peru, tuberculosis held the position of the fifth leading cause of death, specifically impacting the individuals between the ages of 15 and 44, making it the primary cause of mortality within this age group. MDR-TB, multi-drug resistant tuberculosis, is an infectious disease caused by a strain of Mycobacterium tuberculosis that exhibits resistance to the first-line anti-TB drugs. And then during the period of 1996 to 1999, about 5.1% of all tuberculosis cases were diagnosed as multi-drug resistant tuberculosis, indicating resistance to at least two primary anti-TB drugs, namely isoniazid and rifampicin. While in 1999, tuberculosis ranked as the eighth leading cause of death worldwide. Why we are doing this case study is to report the investigation of the approaches to enhance the treatment and control of multi-drug resistant tuberculosis in Peru. Now a detailed introduction into the case study. MDR-TB, multi-drug resistant tuberculosis, is a contagious disease caused by a strain of Mycobacterium tuberculosis that displays resistance to at least two primary anti-TB medications, namely isoniazid and rifampicin, both of which are commonly used as the first-line treatment. During the 1980s, Peru went through the Dark Age, and in the 1990s, when the northern part of the country, which comprises of about 9 districts, was heavily struck with MDR-TB. These diseases can be acquired or can be contacted through transmissions like inhaling droplets from the carrier or from substandard chemotherapy for drug TB. MDR-TB exhibits similar signs and symptoms that makes them indistinguishable through small microscopic examination. However, the diagnosis of MDR-TB requires additional time and specialized equipment for drug susceptibility testing, which would enhance the differentiation of the MDR-TB from the drug-sensitive TB. Based on the first treatment of tuberculosis, the first regimen is estimated to last in the patient for approximately 6 months, while in contrast to this, the standard in contrast to the standard 6 months estimated for this TB treatment, MDR-TB necessitates a prolonged chemotherapy regimen that would last for at least 18 months in the diagnosed patient. These extended treatments involve the use of expensive and potentially toxic medication known as second-line agents. These second-line agents are the second stages of treatment that is administered or that was administered to TB patients, and then the treatment lasted for about 18 months. MDR-TB can be approached through either individualized treatment regimen or through empiric standardized treatment regimen. Here is a brief organizational chart of how the Peru Health Center looked like in the 1980s. We have from the administrative section down to the SES physician, also known as the social and salute physician, down to the community health workers, the NTP physicians, that is the National Tuberculosis Program physicians, and down to the dot workers and then the local health post workers. The timeline for the outbreak of TB and MDR-TB in Peru is given in this slide. The outbreak in Peru in 1983 was the fifth leading cause of death, running among 15 to 44 years old. During this outbreak, 60% of patients who had treatment at most were cured, where up to about 47% of people who started this treatment stopped it even before the 6 month speculated time was up. And between 1984 and 1985, two significant national studies conducted came to conclusion that a high proportion of patients with drug-resistant microbe was caused by many years of substandard chemotherapy, that is, many years of inadequate chemotherapy. While the incidence rate across the country were about 175.9 per 100,000 people in the 1990s, in the 1980s more than in the 1990s. In 1991, about 42,763 cases were found in urban Calo and Lima area of Peru. About 48% of all cases was reported. And then 78% of patients who were having treatment between July and December of the same year of 1991, were cured, while we had about 3.8% who had therapy failure, and then 11.3% gave up on their care, while 2.8% were moved out without confirmation. And then we have a death rate of about 4.1%. Overall, the highest incidence rate for this year was around 243.2 per 100,000 people in the year 1992. In Caraballo, one of the districts in Peru, the frequency of all active TB strains among this age of 15 to 44 was around 800 per 100,000 individual in the year 1993. While in 1994, the WHO, the World Health Organization, conducted a survey of early drug resistance among TB cases in Latin America, in which Peru was among them. Out of the 78 positive smear samples that were collected, 54.4% were resistant to more than one medication, while 18.2 were non-resistant, and then we have 39.5 that were more resistant to more than two medications. Between 1995 and 1996, the PHAO, that is the American Health Organization, also conducted a proportional cluster survey, and they had about 1,500 patients that were tested in Peru. Out of these 1,500 patients, about 15% showed some resistance, while 2.5 of those who had MDR rate was higher than those in the weighted mean and the median, or all across the countries that participated. In the year 2000, both fatality rate and number of patients who quitted their treatment was drastically decreased. The analysis is briefly displaying the challenges that a diagnosed patient in Peru experienced during the outbreak. And these analyses were drafted out from the published research articles, along with the suggestions for future strategies and solutions to the problems. One of the problems the Peru diagnosed patients encountered during this outbreak was the discrimination and castigation they received from the local health center. The healthcare workers at the local health center discriminated against the TB patients that failed at the first implementation of the regimen treatment, and they labeled them as failure. This castigation made one of the patients who was receiving the treatment, namely Joanna, run away from the health center and then had to go to a local health center that is more far away because of the tag that was attributed to her family name. Another problem that was encountered during this outbreak was high rate of patients who abandoned their treatment. During the early days of TB, there was a high rate of patients that abandoned treatment, claiming they feel worse and then they have loss of appetite. In 1983, about 47% of the total identified patients abandoned their treatment within their first regimen. They didn't even wait to finish the 6-month span of the first treatment, let alone take the remaining 18 months to totally cure the TB disease in their body system. Another problem encountered is some of these patients believe in religious group rather than their medical treatment. In addition to abandoning treatment, Joanna's sister named Alicia opted for treatment in a religious group, claiming she's going to feel better because of her belief rather than in a healthcare center. Another problem that was identified from this article is the high cost of regimen 2 treatment. The treatment of the MDR treatment is more expensive and also involves more potential toxic medications. Then also, following the high cost of this multi-drug resistant TB treatment, the success rate was still low, and then this low success rate was really discouraging to the healthcare workers in the health center in the year 1993. Another problem that was identified in this article is the high rate of unemployment and low income. Knowing well the price for the second line drugs of this HDR-TB is not affordable in a low income environment, with an individual earning as high as $5 at the end of the month. It was a major impediment to the implementation of a directly observed therapy in Peru. The last problem we could figure out from this article is the poor policy to cater for the patients with multi-drug resistance TB in Peru. The cost of these treatments range from $504 to about 15,681, thus making it less affordable for these people because they were so poor and then they could not even afford to eat. However, in 1993, on tuberculosis treatment, WHO stated that the patient should be classified into different priority levels. In this context, individuals with MDR, TB, and relapses are assigned a lower priority compared to the recent patients who were just diagnosed of TB and then they were all undergoing their first regimen treatment. This also was a big problem to the people of Peru as majority ended dying, and then the new people who were taking the medications couldn't even proceed for that to take more medications because of the expensive cost.
The solution that can be proposed for effective multi-drug resistant tuberculosis treatment and control in Peru to deal with discrimination against patients with MDR-TB and create a supportive environment, educating and training health workers is crucial. The following steps can be implemented to achieve these goals. Are the first one is by increasing awareness and sensitivity among health workers regarding MDR-TB and the challenge faced by patients. And the other one is by providing comprehensive training on MDR-TB diagnosis, treatment, and management, and enhancing communication skills of health workers to effectively interact with patients and address their concern, and promoting a patient-centered approach that respects patient autonomy and involves them in treatment decisions. Following a meeting to review the current TB policies, the PIHSES team left the meeting with the following conclusion. Participants acknowledge that DOTS alone is clearly insufficient in certain settings. They reached a consensus that all patients with active tuberculosis, regardless of drug susceptibility pattern, have a right to treatment. They propose referring to the individualized treatment based on DST result as DOTS plus, recognizing that this approach is most suitable for areas with robust DOTS programs. And in 1999, SES got permission to treat all MDR-TB patients in metropolitan Lima.
Hello everyone, I hope you are well. I am talking about recommendation. Education the public to combat discrimination against TB and MDR-TB patients is crucial. A strategy for public education include conducting awareness campaign throughout various media channels, dispelling myths and misconceptions, sharing personal stories and testimonials, engaging community leaders and organizations, promoting empathy and support within communities. To enhance the treatment and control multi-drug resistant tuberculosis (MDR-TB) improve, it is recommended to implement a comprehensive strategy that focuses on several key areas. Strengthening healthcare infrastructure, allocate resources to improve healthcare facilities, include laboratories, diagnostic capabilities, and treatment centers. Enhancing the infrastructure will enable better detection, diagnosis, and management of MDR-TB cases. Enhance surveillance and monitoring. Establish a robust surveillance system to track the prevalence, incidence, and geographic distribution of MDR-TB cases. This will aid in identifying high burden areas and implementing targeted interventions. Promoting early detection and diagnosis. Implement a strategy to increase awareness among healthcare providers and the general public about the signs and symptoms of TB, particularly MDR-TB. Encourage timely reporting of suspected cases and ensure access to accurate and affordable diagnostic tests. Strong treatment protocols. Develop and implement evidence-based treatment protocols for MDR-TB that include a combination of second-line anti-TB drugs. Ensure availability and accessibility of these drugs in healthcare facilities to improve treatment outcomes. Patient-centered care and support. Provide a comprehensive care and support service to MDR-TB patients, including psychosocial support, nutritional assistance, and adherence counseling, emphasizing the importance of treatment adherence to prevent the development and spread of drug-resistant strains. Caption: Implement a comprehensive strategy is crucial for enhancing the treatment and control of multi-drug resistant tuberculosis (MDR-TB). Improve. Conclusion. The purpose of this report is to investigate the approach to enhance the treatment and control of multi-drug resistant tuberculosis (MDR-TB). Improve. The report investigated some of the problems in control during the treatment control of MDR-TB, which includes the limitation of the policies. The solution to this problem is also suggested. Will this report has categorized the decision by WHO in 1983 to regard patients with MDR-TB as a lowest priority in local health clinic to conserve resources. It is important to carry out further investigation on how effective this approach is in communities with rapid resources. Thank you. Have a good day.